Hello everyone. Today we are going to talk about biotransformation. Previously, this is known as metabolism, but now it is called as biotransformation. What do you mean by biotransformation? This talks about enzyme mediated chemical transformation, chemical change, mainly of the drugs in our body, mainly to make our a lipid soluble drug to water soluble drug. By making this change, drug becomes easily excretable and not reabsorbed from urine. As a whole, biotransformation is all about chemical changes, chemical alterations, so that a lipid soluble compound becomes water soluble, because of which, first thing is obviously it promotes renal excretion and inhibits renal reabsorption, because of which there will be reduced or absence of pharmacodynamic action. Usually, our body, when a drug enters our body, there are three possible fates. First one is active drug gets converted into inactive metabolite because of this biotransformation. This is most common one. Second one is active drug to active metabolite. This helps us in making the drug, staying the drug for longer duration, this drug acts for longer duration. And third most one is inactive drug to active metabolite. This is something very important, very often asked in your theory questions. This is called as prodrug. Prodrug. What I mean by prodrug is a inactive drug gets converted into active metabolite. Why is this important? Usually, a precursor drug or drug which has entity which has favorable profile, be it PK profile or PD profile. And what I mean by that is better absorption, better distribution, restricted distribution, and all. And PD profile, mainly what I mean by that is reduced side effects. Okay, these will be chosen as an inactive entity and they will be given to the patient. These get transformed into active metabolite. Clear? And usually this precursor drug, majority of the time, not always, but majority of the times, has no biological action. And advantages of prodrug is obviously this. Clear? What I mean by that is it's more stable, more absorption or more bioavailability, and all other things, prolonged duration of action, and as well as more duration of action, less side effects, all these will be there. Usually we remember, it's good to remember four products. One is levodopa, which gets converted into dopamine, and then your enalapril, which gets converted into enalaprilat, and then alpha methyl dopa, which also converts into alpha methyl norepinephrine, and then your dipivefrin. These four drugs, if we remember, it is good. Clear? Now, this is about fates of drug. Then, we are talking about biotransformation. So, what are the types of biotransformation? One thing is based on the time. Is it systemic or pre-systemic? Second one is based on the change. It is either phase 1 or phase 2. These two are most important. And third one is based on the site. Is it microsomal or non-microsomal? These three are types of biotransformation. Now we will start with first one, that is based on time, systemic and pre-systemic. Systemic metabolism. Let us start with this. Basically, this is metabolism which happens after the drug reaches, after reaching the systemic circulation. This is what we all usually talk, and this is responsible for majority of the metabolism. Then comes pre-systemic. This is something very important, very often asked for 3 marks, as well as important for us to understand bioavailability too. In the concept of bioavailability also we spoke about it. See, this is our stomach, clear, and this is our intestine. Okay, and this is our liver. Usually from liver, from our intestine, drug reaches liver by portal circulation. Clear? And what usually happens is, let us say we have taken 100 molecules of a drug orally. This 100 molecules reaches my intestine. Of this, around 80 gets absorbed. Okay, 20 goes into excretion unchanged. It's not absorbed, so it goes into excretion. Now, of this 80, the main function of liver is to metabolize foreign bodies. Usually, all our medications are foreign objects. So, what happens is, of these 80 molecules, whatever have reached your liver, gets metabolized, and let us say our liver has metabolized. This is my gallbladder. Okay, liver has metabolized around 20 molecules, and 60 molecules through inferior vena cava reaches systemic circulation. From here, this systemic circulation, it reaches all our organs and action will be shown. But here, whatever 20 is left reaches gallbladder and is excreted out. So, this metabolism of 20 molecules occurs before reaching systemic circulation. So, this is called as pre-systemic metabolism. This reduces bioavailability of the drug. Clear? And most common site is liver, but for some, even gut wall acts as a site for first pass metabolism. Best example for gut wall is levodopa. For some, lungs act as primary pre-systemic metabolism, and best example for that is nicotine. Clear? Now, why are we reading this? What is the clinical implication? Most importantly, some drugs are not given orally. They are not given orally because they have very high first pass metabolism. One such example is your lignocaine. And high doses have to be given orally, and one such example is your GTN, glycerol trinitrate, or your morphine, or many other such drugs. Clear? So this is first implication. Next one, individual variations will be there in the action of the drug. Individual variations will be there. Clear? With this we have finished pre-systemic metabolism. Now let us talk about based on the type of change. We saw it. Yes? So, with this we have finished systemic and pre-systemic. Now, based on the type of change, that is your phase 1 and phase 2 reactions. Phase 1 reactions are also called phase 1 and phase 2. Now, let us write about examples first. Phase 1 and phase 2. Phase 1 reactions mainly include oxidation reaction, reduction reactions, cyclization, decyclization, and hydrolysis. These are the usual reactions which are included in phase 1. Phase 1 reactions are also called as non-synthetic reactions or functionalization transformation. Clear? And why are we reading this? Mainly because this helps us formation of a metabolite. This reaction helps us in the formation of a metabolite. Okay, and then comes our phase 2. Phase 2 is much more important for us. They mainly include glucuronide conjugation, sulfate, acetylation, methylation, glutathione addition. Because a molecule is added here, these are called as synthetic reactions or conjugation reactions. Fine. Now, these are basically type of reactions. Now we will talk about each reaction in detail. Let us first start with oxidation reactions. Oxidation reactions are part and parcel of phase 1, that is your non-synthetic or your functionalization reactions. For this reaction, usually either microsomal enzymes can be involved or non-microsomal enzymes can also be involved. Here, we need to talk about CYP system, cytochrome P system. Why is this important? Cytochrome P system is microsomal enzymes. Microsomes are always inducible. So there are a lot of issues with this. Clear? Microsomal enzymes, and there are usually the 12 families of this 12 type of cytochrome P systems belonging to 3 families. I'll give you an example. It's easy for us to understand then. Let us say we are talking about an oxidative enzyme, cytochrome P3A4. This is most commonly used, commonly utilized the cytochrome P450 system for oxidation reactions. In this, 3 stands for family, A stands for subfamily, and 4 is with respect to gene number. Why do you want to know about the nomenclature? Because certain drugs, see, these are all microsomal, especially cytochrome P is microsomal. So obviously this is inducible. There are certain drugs can change the way these act. So we need to know about cytochrome P system in detail. Let us take cytochrome P 3A4 and 3A5, as well as second example is cytochrome P 2D6, and then cytochrome P2C19, and then 1A1, cytochrome P1A1 as well as 1A2. See, these are very few, but they are important things. Now, this cytochrome P3A4 system is inhibited by certain other drugs. Let us take example of antifungal enzyme, antifungals like ketoconazole, or your commonly prescribed erythromycin. These are inhibitors of this. Inhibitors of CYP3A4. In the same way, there are certain inducers also. Best example, phenytoin, your anti-epileptics. Clear. Now, let us talk about cytochrome P2D6 system. Best inhibitor is fluoxetine group of drugs, fluoxetine, paroxetine group of drugs, and inducers are rifampicin. See, rifampicin is inducer everywhere. Even your rifampicin is here, phenytoin is here. It's like they are commonly induced. Okay. And then 2C19 system. It is inhibited by omeprazole. And obviously your phenytoin, rifampicin, everything comes here. And 1A1 is something what you have to remember more. Why? 1A1 is inhibited by your fluoxamine, fluoxetine and all, and is induced by smoke. Clear. Now, what happens? Your cigarette smoke. Why am I talking about inhibitors and inducers here? Let us say I have prescribed a patient. Let us say, what shall we take? Omeprazole only. Okay. Now, that is quite often prescribed. And omeprazole, I'm talking about an example now. I have prescribed a patient omeprazole. Now, what happens is this omeprazole is metabolized by CYP2C19 system, but it inhibits CYP2C19 system also, so that when it is taken for longer durations, this CYP2C19 system will be inhibited, resulting in reduced metabolism. Once metabolism is reduced, it means the drug stays in the body for longer duration. See, omeprazole is a wide margin of safety drug. Let us take a narrow margin of safety drugs like theophylline. Theophylline is a narrow margin safety drug. And if a patient is on theophylline and he smokes regularly, okay, cigarette smoke is an inducer, and theophylline is metabolized by CYP2C1 system. CYP1A1 system. Now, theophylline is metabolized by CYP1A1 system, and he is a smoker. What usually happens then? It induces. So, theophylline metabolism will be increased, resulting in therapeutic failure. Am I clear why we should learn about inducers and inhibitors? Now, after this, this is about only oxidation reactions. There are many other reactions in this. In oxidation, we started with cytochrome P system, which is primarily a microsomal enzyme, and we have spoke about the cytochrome P system. Now, we will talk about after oxidation, there is reduction. There is nothing to add here. Reduction, hydrolysis, cyclization, decyclization, all these reactions come under phase 1. See, there is nothing very specific to learn. Let us learn one example for each. Reduction is commonly seen for all these alcohols. We'll remember this easily, so I'm talking about them. Hydrolysis is primarily, let us say, all these choline esters, acetylcholine esters. Cyclization, you have to remember this, you are bound to remember cycloguanyl gets converted into proguanyl. Decyclization, here we already read phenytoin, your anti-epileptics. Yes, same decyclation will also happen with phenytoin here. Am I clear? You have to remember at least one example. Now comes phase 2. Phase 2 is also called as functionalization reactions, or a group gets added to it. Best example for this is usually a glucuronide conjugation. where a glucuronide moiety will be added. Best example for this is your paracetamol. Paracetamol, morphine. Oh, let us remember morphine. Morphine is easy. Glucuronide conjugation, example is morphine. And then second one is acetylation. See, with respect to acetylation, you need to understand that acetylation, where conjugation with the help of enzyme acetyl-CoA happens. So, once acetyl-CoA is involved, there is always a chance of genetic variations. Now, we will talk about acetylation in detail. Let us say patient A, patient B. Drugs which undergo acetylation, best example is isoniazid. At least remember one, actually they include ship drugs. Hydralazine, procainamide, and S stands for sulfonamides. Clear? Now, I'll explain with an example. Now, there are two patients, patient A, patient B. Both are given isoniazid. Now, patient A is a poor expression of acetylation gene, because of which metabolism of isoniazid is less. Metabolism of isoniazid is less. Let us say a patient is a poor metabolizer of poor acetylation, poor expression of acetylation gene. So isoniazid will be metabolized less, because of which there will be prominent side effects and toxicities. In the same way, let us say patient B is overexpressor of acetylation gene. Then isoniazid will be metabolized more, resulting in treatment failure. Clear? For this reason only, majority of Indians are poor acetylators, because of which there is more chance of side effects and toxicities. For this reason only, always for a patient, for a tuberculosis patient, we supplement them with B6, because isoniazid most important toxicity is peripheral neuropathy. Clear? This is about acetylation. You need to remember this. Then comes our third one, methylation. Remember one example for it. For this, it is sufficient. That is methyl dopa. In the same way, sulfate conjugation. All your steroids, sex steroids have sulfate conjugation only. And then your glutathione. With respect to glutathione, you have to remember a lot. Best example for that is paracetamol, glutathione S transferase. See, paracetamol is usually given at a dose of 500 milligram per, 1 gram per kg body. Paracetamol usually in normal doses will be metabolized with what? Glucuronide. Clear? But when taken in high combination, and major will be glucuronide, minor will be glutathione. Okay, but in very high doses, let us say he has taken some 30 tablets at a point, then both becomes major. Glucuronide becomes major, glutathione also becomes major. On glutathione conjugation of paracetamol, there is a problem of there is a small toxic metabolite from this. Okay, this toxic metabolite, let us say, what should I tell you? This is too much for you right now. NAPQ, N-acetyl paraquinolamine, and all this. There are two important things here. One is your glutathione toxicity. Why is this toxicity happening? One is your glutathione conjugation. The other one is paracetamol gets metabolized by CYP2C1. Both results in excessive formation of NAPQ. NAPQ is highly toxic metabolite. Until and unless it was simply glucuronide, it was okay. But once glutathione conjugation starts, this toxic metabolite concentration increases, resulting in hepatotoxicity. Clear? This is about phase 2 reactions. Now, with this background, let us understand one small flow chart. Whenever a drug is taken by us, by any patient, it has to undergo phase 1 followed by phase 2, so that it gets easily excreted. But some drugs directly after phase 1 gets excreted. Some drugs directly enter into phase 2 and get excreted. Without all this also, some drugs undergo spontaneous excretion. This is called as Hoffman's elimination. Atracurium and cisatracurium undergo Hoffman's elimination, where they don't need any enzyme. There will be just a chemical rearrangement, so that drug becomes easily excretable. Example for this is atracurium, and cis adracorium. This is common MCQ common MCQ asked in your exam. Talk about, with this we have finished. With this we have finished based on the change phase of reaction. Now we will talk about microsomal and non-microsomal. Why is this important? See, we should bother about this much more, mainly because, see, we already spoke microsomal. Cytochrome P system is a best example of microsomal enzymes responsible for metabolism. All microsomal enzymes are bound to have inducers and inhibitors. We'll talk about this in detail. Microsomal enzyme induction. Fine. Now we will talk about this in detail. What I mean by that is, see, when you take certain drugs repeatedly, let us take an example. Tell me one enzyme inducer. No, we saw many. Yes, one example. Rifampicin is an enzyme inducer. Now, patient on antitubercular treatment must be using this for prolonged periods. Okay. Now, when we take this drug for prolonged period, it increases smooth endoplasmic reticulum, because of which there will be increased microsomal enzymes. And for this to happen, drug should be taken at least for a period of more than 2 weeks. Okay, and because of which, and why is this clinically relevant? Why are we reading it? Most important thing is, first thing, rifampicin plus oral contraceptive pills. Very, very important. What happened is, let us say, we'll talk about this in a clinical case scenario. A female came to you with she is on OC pills, and she recently got diagnosed as TB, Cox positive. So without giving proper history, OBG started her on rifampicin, ATT. And finally, one day, this female came to the same person telling that she got her UPT positive. Why? Because ATT contains rifampicin in it. This rifampicin is an enzyme inducer. This enzyme inducer. Then enzymes are increased because of, and resulting in increased metabolism of estrogen, because of which there is therapeutic failure. Clear? This is first and most important. So whenever a patient is on any enzyme inducer, we should advise other methods of contraception. One more example. Okay, now phenytoin. A patient who is on phenytoin, they have increased vitamin D degradation, resulting in more of osteomalacia. Omeprazole, smokers don't respond. Their response differs. Yes, because of same policy. And in the same way, previously, long back, just born newborn babies, neonates, were given phenobarbital because it is a potent enzyme inducer. This, when used for prolonged periods, that is about 1 to 2 weeks, it increases the metabolism of bilirubin, because of which the newborn, if they had jaundice, neonatal jaundice, kernicterus will be reduced. Clear? These all are. Now we will talk about enzyme inhibition. Till now we spoke about enzyme inducers. Enzyme inhibition is a rapid process. See, we are talking only about microsomal enzyme inhibition, not allopurinol. It acts by inhibiting certain drugs. No. We are only talking about microsomal enzyme inhibition. Best example for this is cimetidine, which is a H2 blocker, which was used previously, but inhibited the metabolism of estrogen, resulting in gynecomastia. This alone is the example, not your typical allopurinol and all. Allopurinol is not an example of microsomal enzyme induction. Let us be clear with that. Clear? I think with this we have finished biotransformation. Thank you for patient listening.